Imagine a patient just walking through a grocery store. She's 51 years old, going about her day, perfectly fine. And then suddenly, she feels this excruciating pain in her upper back.
Just out of nowhere.
Right, completely out of nowhere. 2 hours later, her hands are weak. 8 hours later, she is completely paralyzed from the chest down.
Which is terrifying.
It really is. And your first instinct as a clinician, if you see that, might be to assume some massive catastrophic immune attack on the spinal cord. But if you immediately treat her for that immune attack, you won't just fail to help her. You might actively cause fatal complications.
Yeah, it is the ultimate diagnostic trap. The symptoms just scream immunology, but the reality is entirely different. And falling into that trap is remarkably easy if you're, overly reliant on just the surface level presentation.
Which is exactly why we are pulling apart these specific clinical traps today. So, welcome to this custom-tailored deep dive. Whether you are a medical student cramming for boards, maybe a young professional on your first neurology rotation, or just, a lifelong learner fascinated by the immense complexities of the human body, you are in the right place.
Absolutely.
Today, our mission is to unpack an absolute masterclass of a text. It's called Mayo Clinic Cases in Neuroimmunology, and it's edited by Andrew McKeon, B. Mark Keegan, and W. Oliver Tobin. We really want to extract a high-yield practical framework for navigating these frankly terrifying clinical presentations.
And the editors of this text present a really fascinating core philosophy right out of the gate. I mean, over the last 30 years, the neuroimmunology field has just exploded.
Oh, for sure. The tech is wild now.
Right. We have high-resolution MRI, flow cytometric assays, live cell-based testing. The diagnostic technology at our fingertips is staggering. But their overarching message is actually a warning. They say that while the technology evolves rapidly, clinical common sense never changes.
Right, because if you blindly follow the technology or just the standard textbook presentation, you miss the actual mechanism of disease.
Exactly.
And to really understand these mechanisms, we need to look at what happens when the central nervous system's infrastructure breaks down, but not in the ways we traditionally thought. So let's look at a foundational case from the text, case 14.
Yeah, this is a vital starting point.
Yeah.
So the clinical presentation is a 12-year-old girl. She develops a subacute onset of cramping back pain, and she has these paresthesias moving up her lower limbs to her waistline.
Okay.
She also demonstrates a positive Lermit sign, that electric shock sensation shooting down the spine when you flex the neck.
Right, classic symptom.
Exactly. But then, over just a few hours, she experiences rapidly progressive, highly painful vision loss, first in one eye and then the other.
Wow. So if I'm looking at this historically, a patient with simultaneous severe optic neuritis and spinal cord inflammation, they would have likely just been lumped into a category of severe aggressive multiple sclerosis, right?
Yeah, almost always.
The assumption would just be that her immune system is generally attacking the myelin sheath, the insulation around her nerves.
Precisely. I mean, for a very long time, neuromyelitis optica, or NMO, was just considered a variant of MS. Both involve demyelination, both cause these catastrophic neurological deficits. But researchers at the Mayo Clinic actually discovered that NMO is fundamentally biologically distinct from multiple sclerosis.
In what way?
Well, it isn't a general attack on myelin at all. It is driven by specific autoantibodies targeting a water channel called aquaporin 4, or AQP4.
Okay, wait, I want to pause on the mechanism there because this is where the traditional demyelination label feels a bit misleading.
It is misleading, yeah.
Right. If the antibody is targeting a water channel, why is the myelin, the actual nerve insulation, falling apart? Aquaporin 4 isn't on the myelin itself, is it?
It's not. And that is the biological twist here. Aquaporin 4 channels are highly concentrated on the foot processes of astrocytes.
The astrocytes.
Yeah, the star-shaped glial cells that help maintain the blood-brain barrier and support the surrounding tissue. So in AQP4 positive NMO, the autoantibody binds to those astrocyte foot processes. And this triggers a massive complement cascade, which is a very destructive immune response.
Okay, so the immune system is actively destroying the astrocytes, not the myelin-producing cells.
Initially, yes. The astrocytes are the primary target. But oligodendrocytes, which are the cells that actually manufacture and maintain the myelin sheath, they rely heavily on those astrocytes to survive.
I see.
Right. So when the astrocytes are destroyed by the AQP4 antibodies, the oligodendrocytes just die as collateral damage. It's essentially an ecological disaster at the cellular level.
So you poison the soil, the astrocytes, and as a result, the trees, the oligodendrocytes die, and the myelin wither away.
That is the perfect analogy, yes.
That distinction completely changes how we conceptualize the disease. It's not a primary demyelinating disease. It's an astrocytopathy that just results in demyelination.
Exactly.
And clinically, that has to change the treatment trajectory entirely. With traditional MS, you might use disease-modifying therapies that modulate the immune system, perhaps waiting to see a pattern of relapses before committing to heavy lifelong immune suppression.
You absolutely cannot wait with AQP4 positive NMO.
Because it's so destructive.
Because the pathophysiology is a targeted destructive complement cascade against astrocytes. A single attack can leave a patient permanently blind or paraplegic. The presence of that AQP4 IgG biomarker dictates that the patient requires long-term aggressive immunosuppression immediately, like right after just one clinical episode.
So you are treating to prevent the second strike because the second strike could be devastating.
Precisely. You don't have the luxury of waiting to see a pattern.
That perfectly illustrates why the underlying how matters so much more than just the surface what. And it makes me think about what happens when the immune attack ignores the central nervous system altogether and goes straight for the muscle tissue.
Oh, yes. The NM cases.
Right. The text highlights a condition where the physical damage is profound, but the immune system practically leaves no fingerprints. Let's talk about necrotizing autoimmune myopathy, or NM.
Case 49 in the text is a brilliant example of this. So we are presented with a 53-year-old woman who developed subacute progressive proximal weakness.
Okay.
She can barely climb stairs or rise from a chair. Her referring physicians give her a 2-month trial of high-dose prednisone. We're talking 60 milligrams a day.
Which is a massive dose of steroids. If she has an inflammatory muscle disease, you'd expect that to cool the fire.
You would, but it yields absolutely zero clinical improvement.
None at all.
None. And yet, her creatine kinase, or CK levels, which act as a biomarker for muscle breakdown, they are soaring over 3,000 international units per liter.
Wow.
Normal is usually under 200. Her muscles are actively dying.
Okay, here's the part of her diagnostic workup that I find incredibly counterintuitive. She gets a muscle biopsy, right? We are told she has an immune-mediated condition. But the biopsy shows scattered necrotic, dying muscle fibers with almost zero inflammation. Right.
The pathologists note that only a few mononuclear cells are seen. If this is an autoimmune disease causing severe muscle necrosis, where are the swarms of white blood cells? Why is the biopsy practically empty of inflammatory cells?
It feels like a total paradox, but it's the defining hallmark of this specific subtype of NEM. The weakness and the necrosis are driven by an autoantibody, specifically the HMGCR antibody.
Wait, HMGCR, that's a key enzyme involved in cholesterol synthesis, right?
Exactly. In this condition, the antibodies bind to the HMGCR protein right on the surface of the muscle fibers. And this binding likely activates the complement system, or it recruits macrophages to directly attack and ingest the muscle fibers.
So the macrophages act like targeted assassins rather than a massive, messy army of T cells.
Yes.
Which is why we don't see the classic inflammatory swarming on the biopsy.
That's it. It's often described as a pouchy immune myonecrosis. Pouchy meaning few or scarce. The destruction is highly specific and efficient, leaving very little traditional inflammatory infiltrate behind. But wait, if the target is the HMGCR enzyme, that brings up a massive real-world connection. Statins drugs like Lipitor or Crestor are taken by tens of millions of people globally, specifically to inhibit the HMGCR enzyme to lower their cholesterol.
Right.
And the text notes that roughly 35% of these NM cases are linked to statin exposure. If millions take statins, why aren't we seeing an absolute epidemic of necrotizing autoimmune myopathy? What is the missing link there?
That is the crucial immunological question. It requires a perfect storm. It's not just taking the statin.
Okay.
Statins inhibit the enzyme, but the body's natural response to that inhibition is to actually upregulate the production of the HMGCR protein to compensate. So you have muscle cells suddenly expressing abnormally high levels of this protein.
They are essentially painting a giant molecular target on their own backs.
Yes. And if you combine that massive target with a patient who has a specific genetic susceptibility, like certain HLA genetic profiles, for example, the immune system suddenly misrecognizes this overabundant statin-bound enzyme as foreign. It generates autoantibodies.
Mm-hmm.
And here is the truly vicious cycle. When the muscle fiber is damaged, it tries to regenerate. But regenerating muscle fibers expressed even higher levels of HMGCR.
Oh, no. So the damage Triggers regeneration, which creates more targets, which attracts more antibodies, which causes more damage.
Exactly.
It's a feed-forward loop of autoimmune destruction. That completely explains why simply stopping the statin medication doesn't stop the disease. The loop is already running.
Precisely. And it also explains why who 2 months of high-dose prednisone did nothing. Corticosteroid monotherapy is almost never enough to break that intense feed-forward loop in NAM.
So what do you do?
These patients require aggressive, early polypharmacy.
The text details that she was eventually rescued with a combination of intravenous immunoglobulin, or IVIG, mycophenolate mofetil, and continued steroids. Can we break down the pharmacological mechanism there? Why that specific trio?
Well, each targets a different part of the cycle.
Yeah.
Steroids provide broad, albeit insufficient, baseline immunosuppression. But the IVG works by essentially flooding the patient's system with healthy, pooled antibodies. These healthy antibodies competitively bind to the FESC receptors on those destructive macrophages we mentioned earlier.
Ah, okay.
By saturating those receptors, the IVIG prevents the macrophages from binding to the autoantibodies on the muscle tissue. It physically blocks the assassins.
That makes sense. And what about the mycophenolate mofetil?
That is the long-term solution. Mycophenolate mofetil inhibits an enzyme called IMPDH, which is crucial for the synthesis of guanosine, a building block of DNA. Now, most cells have alternative salvage pathways to make guanosine.
But the immune cells don't.
Right. Lymphocytes, the T and B cells driving the autoantibody production, they rely almost exclusively on this specific pathway.
That is brilliant. It essentially starves the specific rogue immune cells of the nucleotides they need to replicate without shutting down cell division in the rest of the body.
Exactly.
You use IVIG to block the immediate damage and mycophenolate mofetil to shut down the factory producing the autoantibodies. That's the strategy. And catching this requires recognizing that soaring CK level and the progressive weakness, even if the biopsy looks deceptively calm, which brings us back to the most dangerous territory of all.
The neuroimmunologic mimics.
Yes.
This circles back perfectly to the hook of our discussion. We've seen demyelination caused by collateral damage in NMO, and we've seen muscle necrosis driven by a feed-forward loop in NAM. Both of those require massive, aggressive immunosuppression to stop the damage.
Right.
But what happens when the clinical picture perfectly imitates these crises, but the immune system isn't involved at all?
This is where a meticulously detailed patient history will save you from making a catastrophic error.
Let's revisit case 78, that 51-year-old woman in the grocery store. She has a 50-pack-year smoking history, hypertension, and hyperlipidemia.
Lots of vascular risk factors there.
Exactly. Sudden excruciating back pain. 2 hours later, severe hand weakness. 8 hours later, paraparesis. She cannot lift her legs against gravity, and a T1 sensory level, meaning she has lost all sensation from the upper chest down, plus urinary retention. It is a devastating, terrifyingly fast clinical decline.
And the text notes that the initial treating physicians assumed this was severe transverse myelitis, which is a massive inflammatory attack on the spinal cord. And looking at those symptoms, it mimics a severe spinal cord lesion perfectly.
It really does.
So, as a clinician, if you are staring at a paralyzed patient, how are you supposed to differentiate between an inflammatory attack that needs IVIG and steroids and a mimic that doesn't?
The single most crucial diagnostic tool in this case isn't a lab test or a flow cytometry assay. It's the timeline.
The timeline.
Yes, the hemodynamics of the presentation. Inflammatory myelopathies like transverse myelitis usually smolder. They take days to weeks to reach their absolute nadir. The inflammation builds, the immune cells infiltrate, the damage accumulates.
But her decline didn't smolder. She went from walking to fully paralyzed in 8 hours.
Exactly. Vascular events, infarctions, strokes, bleeds strike with devastating speed. They evolve in minutes to hours because the tissue is being instantly starved of oxygen or mechanically crushed by blood.
Wow, okay.
When you combine her hyperacute timeline with her vascular risk factors, the heavy smoking, the hypertension, you must immediately pivot your thinking away from immunology. This patient suffered a spontaneous spinal cord infarction. She had a stroke in her spinal cord.
How does the MRI help confirm the difference between inflammation and ischemia in the cord? Because if you suspect an immune attack, you are inherently looking for inflammation on the scan, right?
Right. The key is gadolinium enhancement. Gadolinium is a contrast dye that leaks into tissue when the blood-brain barrier is broken. In transverse myelitis, the active inflammation breaks down that barrier, so the lesion will typically enhance brightly with contrast.
But not in a stroke.
No. In a spinal cord infarction, especially early on, the barrier isn't primarily broken by inflammation. The tissue is simply starving. Therefore, an infarction typically lacks that gadolinium enhancement.
I see.
Furthermore, a lumbar puncture, which shows cerebrospinal fluid that is non-inflammatory, so no excess white blood cells, no unique oligoclonal bands.
The text follows this up immediately with another mimic, case 79, which I think is equally treacherous, a 25-year-old man presenting with rapid onset paraplegia.
Yeah, that's a tough one.
In his case, it wasn't a stroke, it was hematomyelia bleeding directly into the spinal cord. And the text notes specific MRI clues that are crucial. T2 hypointensity and T1 hyperintensity before contrast is even given. Why do those specific signals matter so much?
Because they're the physical signatures of degrading blood, specifically methemoglobin.
Oh, okay.
In the subacute phase of a hemorrhage, the hemoglobin in the red blood cells breaks down into methemoglobin, which is highly paramagnetic. This causes the fluid to appear very bright hyperintense on a T1-weighted MRI sequence without any contrast dye. If you see intrinsic T1 hyperintensity in the cord, you are looking at blood, not an inflammatory plaque.
This highlights the terrifying reality of these mimics. Let's say you ignore the hyperacute timeline and you mistakenly diagnose the spinal cord stroke or the hematomyelia bleed as an inflammatory transverse myelitis. You decide to aggressively treat it like the NMO or NM cases we discussed. What happens to the patient?
You inflict immense harm.
Really?
Oh, yeah. You might administer massive doses of intravenous steroids, which can drastically spike blood pressure and blood glucose in a patient who just had a vascular event.
Which is the last thing you want.
Exactly. Or you might start plasma exchange, which requires placing a large central venous catheter and involves shifts in fluid volume and coagulation factors. That is potentially disastrous for someone with an active bleed or an unstable vascular system.
And all the while, you are delaying the actual necessary treatments, like managing the blood pressure, optimizing spinal cord perfusion, administering aspirin or statins.
Exactly. By catching the timeline, the physician avoids administering useless and dangerous immunotherapy and correctly pivots to vascular risk management. It requires stepping back from the expectation of a purely immunological answer just because you are in a neurology ward.
It is the ultimate vindication of the editor's core philosophy. The timeline dictates the diagnosis. Clinical common sense overrides the assumption that every severe neurological deficit is a mysterious autoimmune disorder.
Perfectly said.
Let's recap this journey we've been on. We started by redefining demyelination. We saw how the discovery of the AQP4 antibody proved that neuromyelitis optica isn't a primary myelin disease at all.
Right, it's a targeted attack on astrocyte water channels.
Exactly. It kills oligodendrocytes as collateral damage, and this fundamental biological difference mandates immediate, lifelong immunosuppression after just a single attack.
And from there, we explored the feed-forward loop of necrotizing autoimmune myopathy. We analyzed how a common medication like a statin can upregulate the HMGCR enzyme, inadvertently creating a massive target for macrophages in genetically susceptible patients.
And we saw how this creates profound myonecrosis with practically zero visible inflammation on a biopsy.
Right, requiring precise polypharmacy, IVIG to block the macrophages, and mycophenolate to starve the rogue lymphocytes.
And finally, we navigated the treacherous waters of neuroimmunologic mimics. We contrasted the smoldering, days-long timeline of true inflammatory myelitis with the striking, hours-long devastation of a spinal cord infarction or bleed.
We learned to look for the absence of gadolinium enhancement and the presence of methemoglobin to save patients from catastrophic, misapplied immunotherapies.
Which brings us to a conceptual review. The Mayo Clinic text has a specific Q&A section that really hammers home the metrics required to distinguish these clinical presentations. So as you're listening and integrating these concepts, think about the ultimate diagnostic tool we just discussed, the timeline.
Yep.
If you are evaluating a patient with severe acute myelopathy deficits, at what temporal cutoff should you be highly suspicious of a vascular mimic like a spontaneous spinal cord infarction?
The textbook cutoff to remember is 12 hours. If a patient's severe myelopathy deficits accrue and reach their nadir in under 12 hours, you must prioritize vascular causes, infarctions, or hemorrhages at the absolute top of your differential diagnosis. Inflammatory events almost always take days to weeks to unfold.
It is such a simple, elegantly clinical rule, but it entirely reframes how you view a paralyzed patient arriving in the emergency department.
And it leaves us with a broader, somewhat provocative concept to consider. We spend years studying the precise molecular binding of AQP4, the nucleotide starvation pathways of mycophenolate, and the paramagnetic properties of methemoglobin on an MRI.
Yeah.
But if a simple patient narrative, the difference between it started yesterday and it started 2 hours ago, can completely override an MRI and change a diagnosis from a heavy immunosuppressive protocol to standard vascular management. How heavily should we really be relying on our scans compared to the patient's own history?
It really forces you to question the hierarchy of our diagnostic tools. We treat the scan as the ultimate objective truth, but the scan only shows the aftermath.
Precisely. As you move forward in your clinical rotations or your continuous studies, remember that the most advanced imaging and flow cytometry in the world are still just supplements to a meticulous, inquisitive patient history.
That is so true.
The MRI might show you the what, and the antibody assay might show you the who, but only the patient's narrative will give you the when. And in neuroimmunology, the when often dictates the why.
It's a profound reminder that while the diagnostic tools will continue to evolve and become more granular, the human element of medicine, sitting down, listening critically to the timeline, and applying clinical common sense, remains undefeated. Thank you for joining us on this custom deep dive into Mayo Clinic cases in neuroimmunology. We hope you take these mechanisms, these biological twists, and these crucial timeline rules and apply them the next time you are faced with a complex clinical presentation. Keep questioning the biopsies, keep interrogating the timelines, and keep searching for the physiological truth behind the symptoms.